So everybody was very busy yesterday and very productive. Congratulations to all three groups. We actually have almost an hour of more discussion right now, potentially. But let me refocus and make sure that everybody remembers the marching orders that each of these groups was given, which was, number one, how do our current norms, practices, and policies either provide potential leverage points or limit our ability to broadly implement prevention? Number two, what are the key changes needed in our financing models, scientific models, policies, or implementation models that are going to allow us to make that broad diffusion and uptake of evidence-based programs, practices, and policies? And third, what are we going to do to foster these linkages across sectors? And so those are our three big questions, but I'm in the lucky position of having this mic, so I'm going to ask the first question, which really, I want to go to Larry Palinkas, because I know that it was also both in Shep's presentation about schools, the relationship between Department of Education and other sectors and health, and also in David Chambers' presentation about healthcare sectors linking. And it was a discussion about infrastructure. So an infrastructure for prevention. And Charles Collins' talk got a lot of attention in different groups because it was one example of the creation of an infrastructure within a very narrow prevention area, but infrastructure development. So my first question would go to both Larry and Jennifer and then to the group. What would a prevention infrastructure look like? Did anybody have specific ideas? And then we're going to open the floor for everybody's questions, comments, or reactions.
And I think our group talked about this a little bit, and so maybe I'll start with that. I mean, there was some discussion that right now there's sort of, with the whole silos, you know, that we all do a little bit of prevention and then, but have sort of our different focus is. So, I mean, I think it was Pat who said, you know, the pie in the sky idea is why don't we just have this sort of, you know, youth development sort of, I mean, I think it was like a central prevention agency, which, I mean, is doing that on the federal level may be pie in the sky, but, you know, that there are sort of these models of doing it more on the local level where, I mean, even in juvenile justice and child welfare, you have sort of one court, one judge, one family. So it's dependency and juvenile drug courts are sort of combined. I mean, so sort of as a start, I think that is something that, you know, just sort of doing that, you know, and coordinating in a way. And I don't know if you want to.
So, you know, part of, I think, any infrastructure involves some degree of centralization and some degree of disbursement or division of responsibility, division of labor. When we talked about the community as being the locus of prevention, as Jennifer said, you know, we could imagine, for example, you know, just like there's a Department of Health Services, Department of Mental Health, there's a Department of Youth Development that coordinates all of the prevention activities across the different sectors. And, you know, assigning, as I said, universal prevention programs and resources in some sectors and, you know, more targeted or focused prevention activities in other sectors. But the infrastructure, you know, as we noted, involves coordination so as to avoid duplication of efforts, so that what you see going on in the primary care setting is not, you know, replicated in the school setting. Or in the child welfare, you know, case settings, and that, you know, requires linkages that are based on the, you know, exchange of information, the data or information sharing of the electronic records, but the face-to-face interactions as well. So, if you could imagine a block grant given to a community, which is then charged with figuring out who is in the best position to engage in universal prevention, who's in the best position to engage in selective or targeted prevention, how do you avoid the duplication of effort, to maximize the efficiency of these programs, and how do you exchange information in a way that youth don't fall through the cracks, which further complicates and further adds to the cost.
Okay. Any other reactions from the panel or additional comments before we turn it to the audience? And anybody who has an additional comment for their sector or questions or that they want to bring up for discussions?
Well, so the only thing I'd add is within the group there was a lot of discussion. Certainly thinking about what is the healthcare sector itself able to do in this prevention space versus, at least at the state level, is there a way that one could have a broader umbrella? So I think it relates to this idea of having this separate sort of coordinating office of child and youth development or prevention. But I know the feeling in the group mentioned where things had worked. It seemed like it was at the top levels of the state system, even in the governor's office, where there was some ability to carry that authority when there was a recognition that in the different agencies they're in a lot of cases trying to provide supports to the same kids, but it needed that higher level support. So I think the idea that the infrastructure, if the infrastructure for prevention was seen in parallel with all of these different infrastructures, I would see it being, sort of lateral. I would see that being difficult. It seemed like from what people were saying that when you got that broader state authority to be able to say, okay, how might we be able to, from above, look at ways to incentivize the individual sectors rather than assuming that they'll all do them together. So I think that was one that seems consistent with what came in your group.
Shep, let me just ask before we go away from this, because Larry said put it in the community, give the power, and I presumed he meant geographically defined community, and you said put it above at the state. Is there a difference in the ideas that you guys are promoting?
It's probably, I don't think by saying put it at the state, from my perspective, it would be an either or thing. The assumption is that there's local infrastructure that's needed to be able to deliver the appropriate programs. But when one is talking about the business case and one is talking about streams of resources, it seems like it's at that point that one needs to think at a higher level, just because with the silos, you often have this parsing out of different funds that are actually going to a piece of the same population. So I think it was, in a sense, infrastructure in terms of the delivery is more local, but infrastructure in terms of the resources had to be at the higher level.
Yeah, I think where we're both similar is the idea that it's a vertical as well as horizontal. If you think of it as is currently the case, in strictly horizontal terms, that's where you begin to see reduplication of effort, that there should be, some vertical component to that organization, whether it's from the state to the communities or within communities.
Okay, Shep?
Yeah, I think that what we've got is a laying out of a very fundamental difference, and so the argument can be centered around that difference. What the school group was empowering itself by virtue of agreement is that schooling is the fundamental business of communities. In Janowitz's terms, communities are communities with limited liabilities. They're places where people go off in the daytime, come back in the evening. The thing that's constant is the local school. And the local school, it turns out, has an enormously powerful mandate to serve the values, culture, and problems of local communities. So schooling becomes an incredibly fought after base of community support. Schooling becomes the vehicle for the future. I learned this in Woodlawn, on the south side of Chicago, where I had no background in child psychiatry, but I was told point blank, what we want you to do is to in fact help us protect children so they reach their full potential. And it was children who guided the community mandate. Now the question is, how do we integrate services around schooling in such a way that the metric of children growing up and reaching their full potential is the business of community, aggregated and interacting and supplying the support for children's growth and development. I don't think we can do it with our current separation of health from schooling or from social services from each other, and because the kid gets divided up rather than anybody being integrated. So what I think is we already have a system of information about the fundamental product of community. I used to argue with the University of Chicago economists, Milton Friedman and so on. We should be measuring communities based on the facility of communities to grow children to reach their full potential. That's a metric that's measurable in terms of everything from grades to school successes to careers later. It's a trajectory, and we ought to be orienting toward integrating around that trajectory.
Okay, Jennifer.
Yeah, I just wanted to add, I think we spent some time in our group talking about, while if we're talking about sort of coordinating and, across silos, that yes, you likely would need sort of an entity above that sort of does the coordination, but not to underestimate the community buy-in, which we talked about is a lot of different, that it's sort of clients, organizations, and that, both in defining how that sort of sharing should happen, what should be shared, because without that, you're sort of underestimating, how much they know about themselves and how it operates and on the ground. And then also that, you could have someone who's sort of coordinating from above, but, we all know that in a local community, you could have one or two very, sort of subtly powerful people who would prevent something from taking, whether it's in an organization or in a, just a community setting. And so I thought that was a good discussion.
David, I could tell you were going to say something before.
No.
Okay. Any other, you guys get the last shot before we turn to the floor. Any other comments that any of you want to make, or in response to each other or in your groups? Okay, the first question.
I'm short, I have to lower the mic. Felicia Bowen, Rutgers College of Nursing. This is really exciting to hear all of this talk about synergy and breaking down silos and the idea that came from the schools group of putting these professionals in the classroom. It just makes sense. What we do with these IEPs now are very costly, labor intensive. I work in the community. By the time the child gets evaluated, it's 2 years after they've come to the primary provider or the teacher with the problem, and so that's 2 years lost. And the problems only get bigger and bigger. So this is really great, and we're all here in DC, but how do we take it back to the streets? When is this going to happen? Is there going to be some commitment? I know education is here, but a small demonstration project to say, here's a pot of funds, pick a school, and let's do this. Because when we start to see these improvements, then it just makes sense. So, and my suggestion would be to start with the more problematic schools and put the resources there. And certainly in the community, you would have a comparison. So here's a way to get rid of those blasted eyes off of the reports. But these meetings are great. I don't want to just be excited. Where's the commitment, and when is it going to happen, and when are we going to do this?
So let me ask, was there an agenda in any of your groups to identify this? And in particular, what we just heard in terms of your presentations was Shep arguing, and this came up, the exact words yesterday were, the schools are the site of the potential impact, and healthcare is the site of the money, and the big dollars are really going to be over in child welfare and juvenile justice. How do people see that the site is ever going to get somebody else's money, which I think is implicit in the question about a demonstration project or an action plan coming out of this? Was there any consideration to that issue in any of your groups?
Yeah. Well, just briefly, we're already putting a lot of money into disciplinary training. And so the question is, can we make the training function in a more integrated fashion around the common problem of making a classroom a community function? So I think that before we really get to the financing, we really have to figure out what it is that we want to finance. What is the nature of this system that we're talking about that's emerging, putting the pieces in together so that we can really examine what needs financing. A lot of this really is already being financed. Psychologists are already being trained. Child psychiatrists, are already being trained. The question is, do they ever have to go into a classroom to see what attention looks like so they understand what they're talking about and prescribing? So I think that we could maximize first by getting the model straight and then examine the financial potential.
David.
I think the one thing that was related in the group's discussion was this notion of the importance of really getting the metrics right, that really trying to identify what some of those more proximal measures are, and ideally those that are relevant to what the system within which the program is being delivered is going after. So with the idea that a lot of prevention programs are understood to have their benefits many years down the road, given the short-term nature of the political or even the economic environment, it was seen as so valuable to really try and pinpoint, are there things that we can see in the next 6 months, in the next year, in the next 2 years, which then would ideally make it easier for the system to be able to see that sort of return on investment as it was seen.
Okay, Larry, go ahead.
So the way we talked about it is, focusing on the issue of child welfare, and its concerns about safety as being, the primacy that's given to the issue of safety and the secondary consideration to child well-being. The fact that focus on safety can be both a facilitator for supportive programs, but also a potential barrier. That if safety is the only concern, then most existing systems have, as long as none of the children in their care die while they're in child welfare, they pretty much assume that they've done their job, without realizing that by engaging in prevention, you reduce the risk to safety, and you increase the likelihood of permanency, and you save money that way. But currently the system is set up so that whether it's schools or child welfare or health, communities respond to what's available, and what's available comes, through different funding streams. So, Department of Education issues an RFA for programs in schools, and communities respond to that in order to get funding to support what goes on in school. Well, that's not at all tied to what's going on in primary care settings or what's going on in child welfare settings, and that tends to perpetuate the disconnect and the duplication of effort. So essentially you end up with much more expensive and much less effective programs through that existing system. And being able to empower communities to identify what their needs are, and then point to specific sources of funding to address those needs seems to be a much more efficient. So it may be that a community decides schools are the way to go, and we need to target all of our activities in a school site. Or, primary care, we have a system of community clinics that tends to see most, if not all, of the kids in our communities, and we need to target our activities there. Or we've got such a, juvenile justice problem in our community, that while engaging in universal prevention, we really need to put more dollars into, addressing the issue of recidivism. And those needs are not always going to be the same for every community. So the current system, which tends to be more of a one-size-fits-all, but for different sectors, may not be as efficient as, a community deciding we need this versus we need that, and those decisions not being consistent across all communities.
So I actually think there's a fundamental difference here on the panel. So I want to take this opportunity to try to push this issue, and then we'll move to more questions. Because, Larry, you're advocating for community empowerment and force them to go look from existing funding sources. I heard you advocate differently for a prevention infrastructure, and clearly I heard Shep advocate every community should focus in the school because that's everyday life. And those are really two fundamentally different strategies, and it seems like, so I would both highlight it now, you can comment on it, or we can go, but there's not agreement at this front panel on what the prevention infrastructure should look like.
Maybe we should do both.
Okay, go ahead, Naiwa, you're next.
The only comment I'd make is that this is the right argument. The right argument is, do you leave things pretty much, improve them as well as you can independently of each other relatively, or do you bring it all together around a common theme? And if so, what's that common theme? Raising kids, for me, is a community central function that's hard to get away from, and really is why we have communities in a sense, rather than everybody working in the same location as it used to be. So the argument would be, and by the way, the schools do have a metric that all of the departments should share, namely how kids are doing in terms of behavior and learning. And if you add psychological well-being, which is interrelated, you've got a pretty good profile that would be useful for juvenile justice, for any other enterprise. And that's what makes the information system always more stable at the community school level, because communities recognize that, in fact, the metric of kids growing up, the employment rate later, whether their reading scores are okay early, all of those intermediate steps are the ways you can measure. You can even get economists to say, okay, what's the efficiency of community X in producing kids with higher reading scores, and integrate services around the performance and the adequate adaptation of kids to growing. So anyway, I don't want to repeat the argument. That's what we should do.
So we acknowledge there's a tension and a difference of opinion on this issue. Naiwa, your question.
Naiwa Duan, Columbia University. So I would like to add a couple of comments on the infrastructure issue from the methods perspective. I guess in a sense, previewing what we're coming up with the methods panel later this morning. I'd like to make sure those perspectives get reflected in this very stimulating discussion. And I think there is a very important and promising potential that methodology can be a part of the infrastructure for prevention programs. And by methodology, I mean both statistical methods, mixed methods, technology, especially technology, because a lot of the infrastructure developments that potentially could be very useful really comes from the advances in technology that made that all possible. So I think there are a lot of barriers in methodology, and when we talked about adaptation in the local implementation, the local communities usually don't have the infrastructure, the capability to do a thorough evaluation. And there are not enough statisticians to do all the evaluation that are needed in all the local communities. And so there needs to be some level of technology-based infrastructure development that will allow us and empower the local community to do the kind of evaluation that might be useful to inform the adaptation. And I think we had a lot of discussions yesterday about using local data to inform local planning, etc. And so the methodology potentially could be an important part of that infrastructure. And I would think like to see that we be part of the toolkit that Kelly talked about yesterday. I would think that for the question about the level of application, the methodology infrastructure does not necessarily need to be restricted to one or another level. It could be useful for the local communities. It could be useful at the state level, and potentially could be useful at the federal or even international level as well. And I'm currently working on a study with Richard Kravitz at UC Davis and Ida Sims from informatics at UCSF, and Deborah Astron, who just moved from UCLA to Cornell Tech, on a study about single patient trials, N-of-1 trials. I'll talk a little more about that later. And so part of the study, the first phase of the study, is to build the infrastructure, both the technology and also statistical, to facilitate the implementation of single patient trials, which potentially is a very useful implementation tool for individualized decision making for clinical treatments. At the same time, I call it we use the term single patient trial, but it could very well be a single agency trial that could be useful for a school, for a clinical agency. So I think a good part of the quantitative research we did previously found that there is a lot of interest in both among the clinicians and the patients about the promise of single patient trials that potentially could be helpful to their decision making. But there is a major infrastructure need. The clinicians in community practices don't have the infrastructure to run a trial. So this study attempts to develop the infrastructure. We're developing apps on Android devices for the clinicians and the patients to use to design the single patient trial and to implement the trial, to collect the data and go through. And we are just about to start the recruitment. So I think a study like that potentially could be the type of infrastructure development that will help facilitate the infrastructure needs, I think, for prevention and for many other areas of applications. Thank you.
I agree. Thank you, Nawa. Eric, any responses up here before we move? Larry, go ahead.
I just want to echo what Naiwat said in that, I talked about research practice partnerships, and, community-based participatory research has been used largely up until now to educate researchers about how to work with communities, and sometimes beating them over the head about the importance of listening to the communities and engaging with them. But an equally critical part of doing or developing that kind of partnership is the methodology that provides opportunities for communities as well as for researchers, given the constraints of doing community-based research and good effectiveness studies, good implementation studies. So the things that Naiwa talks about in terms of methods development, I think is key to making research practice partnerships work.
Okay, Eric.
Yeah, this is a really interesting discussion about the question of how cross-sector do we aspire to in terms of prevention efforts. I think that in our groups, as a member of the school group, I think it's interesting to think that, the three groups may have kind of dictated some of the discussion and recommendations and kind of the track in which we take. When you're talking about health, there's a lot of sectors that are responsible for health, child welfare and juvenile justice, a lot of factors that may lend themselves to those kinds of negative outcomes that'll bring kids to those systems. As Shep was saying, schools are viewed as a kind of positive central pillar of the community, and so I think that a lot of our discussion was about recommendations specific to how to improve the capacity of schools to support mental, emotional, and behavioral health of kids. What I wanted to do is at the risk of kind of putting our chips on that space, I think that it's, Shep really summarized a lot of the discussion really well. I think it's important, and reflecting on Dr. Bowen Felicia's request for, what were the recommendations for tangible action? And again, recognizing it's relatively sector specific, I think it's important to highlight one of the themes that came out of our group around a specific recommendation, which is that, one of the levers for, I think, positive promotion of the school's capacity to support social emotional learning, as usually the term is in schools, has been the development of some of these frameworks that get schools on the same page as emotional behavioral health. And those are these frameworks that usually take the form of triangles, multi-tiered systems of supports, positive behavioral interventions and supports, response to intervention. And this has been a real driver of positive progress, I think, within schools around thinking about what are the strategies for doing universal prevention, doing screening and assessment of young people who can then be referred to effective supports at Tier 2 and Tier 3 levels. How can you have consistent expectations for behavior and discipline? And so I think one of the things that I don't want to make sure got lost from our discussion was there was some rallying around, again, it's sector specific, but the question of, are these frameworks that are out there, two things. One, when you go into schools, a lot of times people kind of view them as a cacophony of triangles. We're not 100% sure what all these triangles are. And, so one of the discussions came around to the question of, you can say what you want to say about the Common Core, but it does provide a framework for folks at local levels, local school levels, to actually flexibly try to get to certain kinds of standards. And is there any opportunity to recommend some degree of consistency in what is recommended around social emotional learning as well as academic learning nationally? And is there, are we at the point where that kind of enterprise would be useful? And the second thing around the frameworks is, how research-based are they really? Is there a need for an effort around trying to figure out what the research says, both within school research as well as other sectors, about all of those things, screening and assessment, prevention, Tier 2 supports, intensive Tier 3 supports, and bring that to bear to some kind of consistent framework that is then provided as a guidance or maybe even a policy document for schools nationally to respond to. Again, it's relatively sector specific, but didn't really wanted to make sure that kind of common, I think, theme of recommendation from our group came through. And real quick, the second thing that I think is worth
before you go there, is there any reaction up here?
Yeah, and Shepard, feel free to reflect on whether that seems to be the case from your facilitation, whether that seemed to your ears to be something that was one of the recommendations from the group.
Yeah, well, the only thing I would add to that, and I agree wholeheartedly with what you're saying, I think one of the things we did talk about at some length was the language. Whose language do we use? Right. The psychology language, the educator's language, or what are we going to use for language? For some communities, social emotional raises social class issues. It sounds like you're white, suburban, whatever. But the idea of developing a common language and a common partnership and integrating the disciplines into that enterprise rather than having them connected by referral or worse by police. That's the general idea, but integrating around growth and development, where we happen to have an information system traditionally there. And with some elaboration and some richness, it can be a way of monitoring how everything is working and what agencies are needed and when. So anyway, I guess I've gone beyond
what
you said, but I agree.
And I would ask, Eric, because I think your presentation yesterday was unique in terms of demonstrating with Kelly's how you could mobilize funds. And there's a few specific examples, and I presume that you fantasize that if, in fact, this was part of the Common Core, that money would follow. And so I think that my concern and experience has been, there's language already in the Department of Health, in the Department of Education, which authorizes prevention under several titles, Title I, Title IV, but that in fact, overall, states and school districts are not utilizing those
Right.
funds. That what's happened in the cutback in the Department of Education is even if the language is there, unless there's targeted and categorical funding, which is the opposite of what everybody's been advocating for the last 2 days, it won't occur.
Right.
So that tension, again, between needing targeted funding in order to get prevention and wanting cross-sector integration is a tension.
Absolutely. And I think that fantasizing about more funding for all this work is something we all do a lot of. And so I think that would be a policy question, is how would you actually put both the common language and a framework that's based on research and align it with funding. Certainly not saying we cracked that nut very well.
But you had a second point.
Yeah. So the second point really quick is just that another lever in schools is just that, regardless, it's very true that we have a lot of different kinds of information systems out there that can cause confusion and duplication. But what we do know is in schools that measurement is something that's highly present and valued as part of that culture. And so one of the things that may be also a little bit smaller step would be to convene an effort around trying to review the existing scorecards that are out there around social emotional learning in schools and how well schools are actually accomplishing the multiple kinds of recommendations that might be in that common framework or might just be from the literature. And similar to what a lot of folks are doing in a couple presentations, I think one later today, ask whether or not we can use meta-analysis about what actually works to kind of try to figure out some sort of scorecard that can help schools identify where they're at on the continuum and target areas for improvement. Might be a little bit of a smaller step. There's a lot of that stuff out there, and the question again becomes schools may not know which one is the best measurement strategy to use. So.
Great comment. Any other reaction up here? Larry. Oh, I got the wrong name wrong.
That's
Go
okay.
ahead. Jeff.
Jeff, it's okay. Jeff Sugar from USC and Children's Institute. I'd like to kind of offer a little bit of a boots-on-the-ground perspective on some of these questions, and then pose, I think a shift that needs to occur. But first, Shep, I'd like to answer your question. Child psychiatrists, I think, still are required to do some school observation, although it's probably vastly truncated from the Stone Age when I trained, and we had to spend a half day a week for an entire year at a school. I think schools are the locus of the community. And, I spent a little time doing some mental health observation and work in India and in Indonesia. And, in India, when they want to get out to the local community, even with a healthcare intervention, they do it at the schools, because those, schools exist in every community. Hospitals, clinics don't. When we moved to community mental health, there was supposed to be this vast array of community health networks that were going to take the place of state institutions. Well, most of us who lived through that know it didn't happen. But schools are there. Now, a problem that I see, when we talk about schools versus primary care is a great place to deliver primary care medicine. But if you're talking about delivering social, emotional training, it's not going to happen. If you treat kids in a primary care setting, you're going to get a very medicalized treatment for social problems. And I think we've already got that, and it hasn't worked very well. The problem that I see in the school, I have worked in some clinics, and some of them very well intendedly had great school-based interventions. The only problem with that I think still goes on is parents like to drop their kids off at the school and pick them up at the end of the day and have the kid fixed. No less a current leader than Thomas Insel, the NIMH director, at a meeting on bipolar disorder a few years ago, when he was talking about how we really have to focus on finding the biology of bipolar disorder in these little kids, and we're going to treat it, and it's going to be wonderful. And I said to him afterwards, how can you think about kids in the absence of the parents? And he said, well, wait a minute. We're in an age of no-fault parenting. If we try to talk about parenting practices and, the effects on kids, we're going to have parents groups angry at us. Well, I'd like to, I didn't say it, but I should say, tough shit. They should be angry. Or, someone has to get angry about this. It's just struck me as crazy on a policy level that when we have kids in our clinics, and it's very clear that the parents are depressed. I've worked in clinics where I've had some kids who have psychotic parents. The answer is, we'll send them somewhere else and they'll get the treatment. Well, these parents are already doing all they can do to get the kid to the clinic. And in one case, I had to file a DCFS report, and that got the parent into a clinic. But it's actually, it's kind of insane that we can't treat parents and kids together at the same place. And as far as the schools go, I think, there really needs to be a focus not just on educating the kids at the school, but educating the parents. And I think I've used
That's a good comment. But I would also challenge what didn't come up in anybody's presentation is the local shopping mall. That, in fact, parent engagement at schools is often low. If you listen to David Hawkins talk about communities that care, how many parents can you get in? But everybody shops. And so I'd encourage us to expand our loci. But it was a good comment, Jeff. Thank you. Next question.
So I just have a comment, and I fear my comments are going to be kind of boring compared to our passionate comments before me, but I wanted to share some information I thought might be useful for this group to be aware of. It's a program under development by our colleagues at the CDC, in particular the Community Preventive Services Task Force, kind of the liaison group or partner group, sister group, what have you, to the USPSTF, which is looking at the clinical preventive services. This is looking at community preventive services. And one of the things that I've heard in this discussion, bringing us back to more fundamental needs, which Shep referenced multiple times, getting people to talk to each other and creating that dialogue between groups, plus just getting the information out to different sectors, including decision makers and leadership folks who don't understand the programs but feel like something should be done. We talked a lot about school shootings yesterday in our group, and often there's this passionate cry for help, but they don't know what they should be doing and how can they find information. So, getting to my point, the folks at the Community Guide are developing what they're calling a learning system, and I'm reading the slides because we just had this presented at our Prevention Research Coordinating Committee group at the NIH, so I'm not familiar with the details, but I can share some information. And they're developing a decision and implementation support system, and basically this is a learning system, as they're calling it, to assist decision makers to identify and select programs, evidence-based strategies, and so that they can meet specific goals while matching their needs, constraints, financial or otherwise, whatever their constraints might be, and available resources. They understand that there are lots of challenges to implementing these programs, including varying levels of skill sets, which I've heard a few times. There are various demands and limited resources quite often in what they're able to do. Their goal is to promote collaboration among decision makers and across lots of sectors. And I'll just read a few off of the slide. And some of them have been referred to. They were in David's slides and others. So the NIH and HHS systems like Healthy People or Phoenix, which we heard about earlier. And this is all building upon what the Community Guide is already putting out. Other systems in the federal government which come from the EPA or the Department of Education for data that might be available that can be layered on top of this. And they also mention state systems and healthcare delivery systems and so on and so forth. Their goal is to have a system in which, one, you can use it as a resource to go and get the information that you might need depending on your skill level, but one is to make it a dynamic system so that there's a dialogue about how these programs can be implemented across the sectors, sharing some of these lessons learned and issues or roadblocks that people have. And one of the things that I think I'm going to go back to them and mention too is building in evaluation strategies and needs assessments and things like that so that people can go and figure out how to assess their programs. So I just wanted to share this while we have all the sectors in the room, that it's something that's under development by the CDC, and it will be launched fairly soon is my understanding in a phased approach, so it won't be a full implementation at once because if funding drops, they want to make sure they can get the basic piece out. But I think this will be one tool that this group, a representative from this IOM committee, and I'm happy to talk to them as well, can take back some of the things that we've talked about here and say, we'd like to include these in your system as you implement it, because we've identified these needs. So I thought this would be a helpful thing for people to know about, because it sounds like the resources and the dialogue. It's not available yet. The system is not launched yet. They're just piloting right now, but we've had a preview and a sneak peek of it a little bit. So I wanted to make sure that you knew it was out there.
Do you know which, can you specify like which division, which center at CDC?
I don't know. Where does the community guide sit?
It actually sits outside of CDC. It's not part of the CDC. It's sort of adjacent to us. So it's enmeshed in a way, but it's not under any particular center.
Okay, all right. That sounds like Northrop Grumman.
Yeah, yeah. And we talked yesterday at one of our collaborative meetings about connecting with the community guide anyway. At CDC, I'm sure, is sitting right here. But
I just saw Bob in a meeting the other day.
okay, so I mean, you can share more details as well. But in those discussions, we could try to integrate other pieces into this system. So.
Thank you very much. That's a good information. Thank you, David.
Hi, I'm Dave Brent, University of Pittsburgh. I was just thinking that two rules that I was taught in psychotherapy. One is avoid premature closure, and the other is to avoid false dichotomies. And I was just thinking about both of those when the discussion was going on. You know, should it be the school or the community should drive things, and to what extent do we need this centralized agency that's going to impose or direct or coordinate prevention? So that's one dichotomy that I'm hearing. And another one is intervention versus prevention. That's actually been unspoken because the focus has been on prevention, but in fact, you know, we know that it's much more of a mixture because, for example, somebody brought up the issue of a psychotic parent. Well, so the parent's in the medical model, so to speak. The kid may not have an illness, but clearly they're at risk. So I'm just concerned that by splitting off these different components, we're losing an opportunity because, as Mary Jane, I think you said, the money is in health and in child welfare and juvenile justice, and the needs are elsewhere, so that unless we think more holistically, I'm just concerned that we're going to end up having good ideas without money. And so I would just want to make one proposal, is that perhaps we need some help from an economist to try to model different assumptions and different allocations of resources. That's one. How much should be in prevention? You know, can we take from other places that are the effects of not preventing things and move it to prevention, and what would that look like? And the other thing I would say is, in terms of avoiding premature closure, I could be convinced by anybody who's sitting up there that their idea is right. So maybe we need a horse race, and that you know, if we can articulate what the alternatives are, let's find out, you know, which is really the best way to do things.
I think those are two really good ideas, David. Thank you. And we'll make sure they get logged. Hendricks.
Yeah, Hendricks Brown from Northwestern. I wanted to come back to a couple ideas. First of all, I think all of the ideas in here are moving towards this integration. And David just pointed out these, and the boundaries that we have created in here are, in a sense, suboptimal boundaries. And we've been dealing with the world as it is. I think it's important that we think about the world as it could be. And we think about this as a mission around what the IOM is doing in here. So there's a different perspective. I think what we've been thinking about is, you know, when implementation, sort of the early stages of implementation came on, you know, we talked about diffusion of innovation with Everett Rogers. Diffusion is not a very good word to try and get things to happen. Dissemination is a little bit better, but implementation is a strategy. It's a clear, defined strategy. You have an idea of where you want to go, and you have a drive for trying to make that. What I think we do need to do is take, Mary Jane's question of creating an infrastructure for prevention as the goal of what we're doing in here. So here's a suggestion about trying to do this at sort of a grand scale. What if everybody's comments over here, they're not identical in here, but they share an incredible amount of commonality about what we need to do. And instead of complaining about here are all the breaks that we have, why don't we think about an opportunity that we would drive forward if it's important enough for our country in here that we try and create that kind of model and use it and test it out in specific communities. So 3 things seem to come up. One of them is try and make it simple ideas in here. One is getting alignment of the goals. If the goal is to keep your juvenile justice system in place, that's just an improper goal. We can't get anywhere if that's what happens. And child welfare is designed that way, to survive. We all are worried about survival of these institutions. Everybody is interested in this one. So we need some sort of a mechanism, like a waiver, to try to get through this kind of really tough period of time where people are trying to survive in their institutions and organizations. The goal, I thought, was something that Shepard pointed out in here, is constructing a system so that children live to their full potential. I think that's something that almost everybody could get around. If we keep everybody on that target, I think that would be really useful. The second point in here is about getting the incentives straight. And we have so many things in our system that are not getting things toward that particular goal. It's going and driving the other way. Well-being is not on the table in child welfare, even though it is in the legislation in here. And so the question is what can we do on this one? I do think we haven't talked very much, sometimes it came up in the group in here, about behavioral economics. I think the idea of trying to get these put together incentives that move forward what we need to have happen, what we would want to have happen, ideally, I think is a really creative kind of way of doing this one. And so I'm going to mention something about this one. I think we need waivers to give us that flexibility because we don't have that flexibility now. But there may be a couple places in certain states and certain communities that we might be able to do it. The third is getting all of the resources available. We need to have the kind of knowledge base of all of the researchers, of all the people who are the practitioners, the professionals in here to be able to make those things happen. So I'm trying to think of what would a waiver look like in here. We talked about waivers in Medicaid before, but what we really are looking at is waivers at the state level, including Medicaid, but also the level of SAMHSA, funding how states use their money for prevention services, for example, education, juvenile justice, and child welfare. Now that seems like a big, tall order, but if we're ever going to get to this kind of creative idea of would a program work if we were to align all of these goals together for a purpose of helping and facilitating the development of children, that's what we're going to need in here. I would bet that there are some places where we could begin to start thinking about these kind of connections and bringing all of these together. And it would be good to do this as a test model across all of these different sectors that we're talking about and need to come together.
That's what did they call it? Hairy, audacious, great proposal.
So I have an answer for Hendricks. It's
All right.
a small one. So I am tangentially involved, so I don't know all the details. Other people in the room also, I think, are tangentially involved. But in the president's, in the appropriations bill in fiscal 14, there was language around the performance partnership pilots, which are, the idea is to get waivers for up to 10 communities to focus on improving disconnected youth outcomes. And the idea is that it's supposed to be waivers across education, labor, child welfare, SAMHSA, runaway and homeless youth, all of these programs. There was some information put out through the Office of Management and Budget. It's being spearheaded by the White House about these this summer, and then there is anticipated to be more detailed information coming shortly. But the idea is that there should be communities that are actually proposing, these are the silos that are preventing us from serving disconnected youth. I will say I haven't seen a lot of the word prevention in there, and it just sort of struck me as I was sitting here listening. But there's also an evaluation component that's been discussed, and I know a lot of us are trying to think about what would an evaluation of these look like, because it's going to be pretty complicated. But I just thought I'd put that out there, and I think people might be interested in following it. I will say CMS was not necessarily part of the language that was put forward in that bill.
Thank you, Lauren. I think that's a really great idea, and as a workshop, as a forum, we'll follow up on that and have more information for people next time. Well, our time is just about up. I'm going to give the panel members, if you want a crack at any final comments. Go ahead, Jennifer.
It's not, I just feel like we've been talking a lot about how there's a lot of funding in juvenile justice, and I don't think that that's true. And also, when we're talking about that system, there is a fraction of that system that is incarcerated, which I think a lot of times when we're talking about, that's what the ones that are confined, the kids who are confined or detained, and that is certainly a very expensive, but there is a move more and more to diversion and community-based alternatives, which is also part of the system, and that prevention is important. So I just didn't want that to be lost.
No, we just want your money. That's it. Thank you, everybody. Thank the work groups yesterday who did a really good job. Thank your leaders who spent last night maybe glancing at TV or the soccer game, but really doing their homework. Thank you. And we're going to have a short break. We're going to come back at 10:35. You only get 15 minutes. We're going to catch 5 minutes, and that's going to allow us more information and time later. So 15 minutes from now, everybody back here.